Thanks for coming, guys. All right, well, I just want to send my empathy out to all you pregnant women who are surviving the 100-degree heat this week. One of my kids was born in the summer, so I feel your pain. Can you guys hear me okay? Okay. So we're going to kind of go through some slides. One thing I hate when I go to talks is just listening to people read the slides that are on the paper. So I'm going to try to give you separate information besides what's on the slide as we go through. But yeah, if you have questions, write them down. I'm happy to answer them. We just kind of like to go through this talk, and this is kind of an extended version of the talk I give parents when they come to meet with me in my office. I don't usually have an hour to talk to them, but I'm happy to talk to you guys for an hour and let you know some of the things we want you to know about when your baby comes. So, you know, to prepare, I think there's nothing you can do to totally fully prepare for when your baby comes, but a lot of people do go to classes like this or birthing classes or breastfeeding classes, and so that can kind of give you a little bit more comfort level with what's going to happen when the baby comes. And a lot of people get a lot of books, what to expect when you're expecting or the first year after that, and those are helpful too, but remember that not everything goes according to the book or according to what the class says. So we try to prepare you for some of the other things that might come up that might not be the normal. When you talk about where you're going to deliver the baby, one of the things you might ask the hospital is if they have a NICU. Most of the hospitals in Omaha do. I think the only ones that don't have a full-time NICU are Midlands, Emmanuel, and let's see, Lakeside has a smaller NICU, Bergen, UNMC, Methodist, and Creighton all have big NICUs. So I think that's most of the hospitals where we have babies. Children's also has a NICU that gets referrals from a lot of outside hospitals and even some of the hospitals in town. So it's nice when you have a NICU because if something is wrong at the delivery, they have people there right away that can help with the baby right away. A lot of people like to go and meet their pediatrician before they have the baby, and so I get those visits quite frequently. Parents will come in and sit down with me ahead of time and ask me questions, kind of get an overview of our office and how it works. A lot of people want to know about hours. We talk about, you know, are we open regular business hours? Do we have weekend hours? Do we have evening hours? So I think that varies from office to office. I think most pediatricians are open a little bit on Saturdays. That's pretty standard. And a lot of people have at least 1 or 2 days a week where they might start early or stay late to help accommodate parents that are working, and we do that at our office too. Some things you might ask your pediatrician is just kind of what their schedule is in terms of when they see the baby for checkups, if they follow the standard vaccination schedule, or if you guys have questions in particular about certain vaccines. I get that question a lot when I meet with parents. Ask about sick visits and how easy it is to get an appointment if your child's sick that day. How long, you know, does it take a day or two to get in, or can they usually see them the same day? And then for people that have more than one child, sometimes they're wanting to group siblings together for visits, and that's a really common thing. You might ask about how you get answers. If you just call with a question, do they have nurses that take those calls? What do they do at night and on the weekends when the office is closed to accommodate your questions? All the children's offices use a nurse line at night that actually takes all of our phone calls, and if they have concerns about what you're telling them, they just get in touch with the doctor that's on call for that office. So most of the children's offices would be able to accommodate you for sure. We all use that service. And then during the day, our offices have nurses that answer phone calls all day and talk with the doctor about what your questions are and get back to you. So usually I think most pediatric offices do a lot of phone calls. That's a big part of what we do every day, and try to help parents determine if what's going on with their child is a normal thing or something that can be watched at home, or something where we need to actually bring the child in and take a look at them. So that's an important question to talk about. And then of course we always recommend that your pediatrician be board certified. That means that we've taken the test through the American Academy of Pediatrics, and that we you know, that's kind of a rigorous thing that we do, and so that we're trying to follow those guidelines that the American Academy of Pediatrics recommends for healthcare for kids. So then it's always like, what do we need to get before we bring this baby home? What do we need to have at home? So you have to have a place for the baby to sleep. You want to get a crib with a firm mattress. The firmer the better for babies. That helps decrease the risk of SIDS. We know that babies who sleep on a softer mattress have an increased risk of SIDS. And all those beautiful crib bedding sets with the bumper pads and the matching blankets are kind of a waste of money because you really aren't supposed to put them in the crib anyway. So if you do get one of those for a baby shower, you can either return it or use the nice quilt for something for the baby to play on the floor when they get a little bit bigger. But they're really pretty. They're just not something that we're supposed to use. So you don't need a lot of blankets. You probably need a lot of sheets because babies pee and poop a lot, and they'll pee and poop and spit up on your sheets. So you need to have 3 or 4 crib sheets so that you can cycle those through the laundry. I think bassinets are great when you have a baby, a new baby. I have 3 kids. My first one, I wasn't very smart and I didn't get one. And then he wasn't a very good sleeper. My second one, I wised up and got a bassinet. And the reason that newborns like a bassinet is it's a smaller space. They wish they were back inside mom. Inside mom, at the end there, they're in the uterus very tight, swaddled up with their arms and legs, curled up towards their chest. And that's how they like to be. So when they get out in the world and we lay them in this big crib and it's very open and cold, they don't like that. So babies do tend to sleep better when they're swaddled up and in a smaller space like a bassinet. So especially if you're breastfeeding, I think it's really nice to have a small bed like that or pack and play, something that you can easily move from room to room, or you can have it right by mom when she's sleeping. So that's a good investment, I think. Most people like to have baby monitors too, although in the beginning you might not need them that much because you're probably going to have the baby pretty close to you most of the time. You need a car seat to take the baby home, so that's one thing they'll ask you about at the hospital when you deliver. Do you have your car seat? Can we see it? And actually one thing that some people don't realize is car seats expire. So if you turn the car seat over, the actual infant seat, there's a date stamped in the bottom. So if you do get a car seat from family or friends, you want to look for the expiration date and make sure it's still good. I think most of them are about 6 or 7 years before they expire. And you also kind of want to avoid car seats that have been, in an accident. If you get one from a friend or family member, make sure it's never been in an accident. But those infant carrier car seats are what you want, and you're going to put those in your car rear facing. If you have trouble, there's lots of resources. Most police stations will let you come in and check and make sure it's tight enough. So you want to make sure you have your car seat ready to go. Most people like a stroller. A lot of those can click in with your baby car seat. Bouncy seat most people have, or a swing or something that kind of has some motion to kind of help soothe the baby. If they're fussy, babies like a little bit of motion too, because remember, they still want to be back inside mom. When they're inside mom, mom's moving around all day. That motion is soothing to them, that kind of swaying motion. So a lot of the newer swings, I think, are those little cradles that kind of go side to side, and I think those are really cool, but I never had one. And then feeding supplies, you're going to need a way to feed the baby. Most moms now are breastfeeding, and that's what we encourage, but if there ever is a time when mom's not able to breastfeed, or they need to supplement a little bit, or dad's going to help feed, or mom's going to be gone for a little bit, it is nice to have just a little bit of supplies to feed the baby if you need to. And if mom's going to breastfeed, a breast pump. One thing that I think a lot of parents don't realize is that you can rent really good breast pumps from either the hospital or like Kohl's Pharmacy or Walgreens, those good double electric Medela breast pumps. So if you're not sure how feeding is going to go, you don't want to spend the $300 on your own breast pump, it is safe to rent one of those hospital grade pumps from the hospital, and I think they're about $50 a month. And that way you could at least have it for that first month right when you get home, and use it. And then if things go well and you want to buy one, then you can always go and buy one. But I think a lot of people do get them as gifts too. And just remember, just because it costs more money doesn't mean it's better. I think a lot of the baby stuff now is really marketed towards, oh, this seat has 5 different reclining positions for the high chair and 20 toys on it. And sometimes just the plain and simple, basic, straightforward stuff is better. So don't feel like you have to buy the top of the line everything for your baby. Your baby's not going to care if your high chair has 5 reclining positions. They just want to sit in there and eat. So you don't need the most expensive thing that sings songs and plays music and lights up all the time. When you pack for the hospital, you want to have a few things with you, I think, to help feel more at home there. I think for mom, you want to make sure that you have a pair of pajamas or something besides that old hospital gown to put on after you're done with the delivery and kind of recovering, because you're going to have lots of visitors, and so the hospital gowns are kind of awkward. If you are going to breastfeed, it's really nice to get a pair of those nursing pajamas or nursing bra so that you can nurse more discreetly if you have people visiting. Or bathrobe that you can put on over your hospital gown. Flip-flops or some kind of slippers are good too, so that when you're walking around in the hallway you don't have to walk in your bare feet. So some slippers or flip-flops are good. A couple outfits for the baby, at least one to go home. they'll kind of put the baby in those little t-shirts the first day or so, but most people bring a couple outfits. If you are going to breastfeed, I think it's a really good idea to bring your nursing pillow with you, Bobby pillow, or there's a couple other ones. My Breast Friend is one, because you're going to want to work on breastfeeding while you're there with lactation, and those can really help you position the baby better. And then whatever electronics you need for pictures and videos and calling family, camera, laptop, cell phone, things like that. And then your car seat, obviously. So you'll need your car seat before they'll let you go home. So those are a few things. Some moms like to bring an iPod or something so they have nice, relaxing music to listen to while they're in labor. When you go to the hospital, if you fill out your paperwork ahead of time, then the hospital will contact the pediatrician and let them know that you've had your baby. So you don't need to worry about calling us yourselves. The hospital will take care of that. When you deliver, the nurses and doctors are going to assess the baby there right after delivery. Usually the labor and delivery nurses do that if there's no problems, and assign APGAR scores, which just are a quick marker of how the baby's doing right at that moment with their breathing and heart rate and color. If the baby's good and there's no issues, the baby's breathing is fine, heart rate's fine, temperature's fine, the pediatrician will usually visit in that first 12 to 24 hours after they're born, depending on what time they come. Most of us make rounds first thing in the morning, so if you have your baby at 4 in the afternoon, most likely you won't see the pediatrician until the following morning unless there's a problem. If there's a problem with breathing or temperature or blood sugar, then they're going to call us right away. Most of the time at those hospitals that have a NICU, if it's a really emergent thing, the NICU is usually there looking at the baby before we even get there. So that's really handy, because then we get the baby assessed and get any interventions going that need to be done. So the time is of the essence with kids. And if you have a normal vaginal delivery, you'll usually stay about 48 hours in the hospital after you deliver the baby, about 2 days. And so we'll see the baby usually twice before you go home. And if you have a C-section, it's usually 3 days and sometimes 4 days after you have the baby before you go home. And that depends more on how mom is doing. Really, the baby could probably go home after 48 hours, but we like a little more recovery time for mom with a C-section. So every day that you're there, the pediatrician will come, check your baby over from head to toe, listen to their heart, feel their tummy, check their throat, hips, things like that. We'll kind of talk about the exam and talk with you about how it's going, how the feeding's going, if they're having wets and poops, if mom's having any issues with her health after the delivery, if the baby's maintaining his temperature. So we'll go over all that stuff with you. I kind of talked about this a little bit already, but at delivery, we're going to suck out the baby's mouth and nose. We're going to stimulate him and kind of clean off all that coating that's on them inside mom. That's called vernix, that white cheesy coating. We're going to clean that off. Stimulating helps babies breathe. So you might watch the nurse do it and think, wow, she's being really kind of rough with that baby. But sometimes we have to be pretty vigorous when we stimulate them, and that's not going to hurt them. We rub their back really vigorously and kind of dry them off. That helps get them jump started so they realize they're in the world and they're supposed to be breathing. So we like to hear that good loud cry, and that's part of how we do that. And then at 1 and 5 minutes, they do those APGAR scores, which look at their color, their tone, their heart rate, and their breathing, and kind of their response to our interventions. And we like to see APGARs 7, 8, 9, 10. But whether your baby has a good APGAR or bad APGAR doesn't necessarily mean things are going to be good or bad down the road. Some babies just kind of forget that they're supposed to breathe right at delivery and might have a low initial APGAR, and we stimulate them, we remind them that they're supposed to breathe, and then they're fine. So that's just a little quick assessment that we do. After delivery, they're going to put some ointment in your baby's eye that helps prevent some congenital eye infections, and that's an antibiotic ointment called erythromycin. We also give 2 injections. Vitamin K is to help the blood clot, and that's something that helps prevent bleeding diseases in newborns. If you don't get vitamin K, the baby can actually have pretty severe bleeding, and one of the things we worry about is what we call newborn hemorrhagic disease, which is actually bleeding into their brain, and that can cause seizures and brain damage and even death. So that's obviously a worrisome thing. So I do occasionally have parents refuse vitamin K. I don't know why, because it's a shot or a medication and they're not comfortable with it, but really, we really strongly recommend it. It doesn't have a downside. The baby's body hasn't made all of its own clotting factors yet right when it's born, so this helps kind of get them through that first couple weeks until their own liver can start making the clotting factors that help their blood clot. So it's really a good thing for your baby. If you have questions about it, you can talk to your pediatrician, but I would talk to them about it ahead of time, because after delivery, when we get those phone calls, sometimes it's hard to get that all sorted out, and we want to get that vitamin K in them in that first few hours after birth. And then we do recommend a hepatitis B vaccine after birth. That'd be your baby's first vaccination. And the reason that we do that is because sometimes moms can carry hepatitis B and not even realize it. You should have been screened for that by your obstetrician, but sometimes our screenings can be a false negative, so mom could maybe be a carrier even though her testing was negative. And if we give that hepatitis B shot within the first 12 hours, that really helps prevent transmission to the baby. So that's another one that we strongly recommend, and we really don't have a downside to that. It gets in their system then, and they're protected, hopefully, from contracting hepatitis B if they were exposed. And so in the first 24 hours, you know, most babies are alert initially after birth, and usually if you're breastfeeding, we try to get them on your breast within the first 30 to 60 minutes after delivery, because they're usually alert and they'll have a good breastfeeding that first time. We'll do a lot of skin-to-skin contact. That's a really important bonding time for mom and baby. And we're going to keep track of their temperature, their feedings, their wetting, and their pooping. And we'd like them to poop and pee at least once in that first 24 hours. If we get over 24 hours and we haven't had any urine or we haven't had any poop, then we start to get a little bit concerned. And so we might look into that a little bit further depending on if there's anything else going on with the baby. We might give them a little supplement to see if they'll pee. That's usually the easiest first thing to do. Sometimes if they haven't pooped, we just use a thermometer to stimulate, put it inside their bottom there and do a little rectal stimulation, we call it, and see if that'll get them going. But you're not going to nurse. You're going to hear a lot and read a lot in the books about you're going to breastfeed every 2 hours. But that first 24 hours, you're probably not. The babies get kind of sleepy after that first good breastfeeding. They're going to just be quiet and want to be held, and that's fine. You don't have to feel like you have to try to get them on there every 2 hours. You're going to kind of follow the baby's cues. When they're awake and starting to root around, then you're going to try to put them on there. But it's also time for mom and dad to just hold the baby and bond with the baby. Try not to be overwhelmed with visitors, because some people want to come immediately as soon as the cord is cut and see the baby. And I think it's fine if you tell them to wait a couple days. Your baby's still going to look like a baby in 2 days, so you don't need to have everyone congregate at once if you don't want to. And if mom needs a nap, it's fine to send the baby to the nursery for a couple hours. That's not going to mess anything up. So if you feel like you're just kind of overwhelmed and you need to just turn the lights out and go to sleep, don't feel guilty about sending your baby to the nursery for a couple hours. That's why they're there. That allows the nursery to actually get some testing done and assess the baby, so it's certainly not a big deal at all. As far as feeding, I've been kind of throwing in a lot of comments about breastfeeding, but there's two choices. You can do breast milk or formula. The American Academy of Pediatrics really recommends that everybody try to breastfeed. If you can breastfeed for the first year of life, that's great. There's a little bit of pros and cons to both, but we want to plan to feed that baby once that first 24 hours is over. Then you're going to start picking up your frequency and do it every 2 to 3 hours. I kind of put on here they're kind of dazed and confused the first 24 hours, so they're kind of sleepy. What you're going to look for is that rooting. They're kind of trying to suck on their hand, turning their head to the side. Sometimes if you hold them, they're kind of turning their head and looking, whether it's mom holding them or dad or somebody else. So those are the signs kind of before they're really screaming hungry that you want to look for as cues that they're ready to eat. Breastfeeding is natural and cheaper. The first 3 days after you deliver, mostly what you're going to be giving the baby is colostrum, which isn't very much. It might only be 10 or 20 milliliters for a whole day. So that's not even an ounce. A lot of moms worry. They say, well, I don't think the baby's getting anything. We expect that your baby's going to lose weight after they're born. All babies do. That's kind of the way that nature works. And so it's okay. We want you to nurse. We want that baby to get the colostrum. Putting the baby to your breast is what's going to tell your brain to start making milk. So we want to go ahead and do that. And we expect your milk to come in around day 3 after delivery or day 4 sometimes. But colostrum is still really, they call it liquid gold because it has lots of antibodies in it and good fatty acids. And so don't worry if you feel like your baby's not getting that much. We monitor their weight, so we make sure they don't lose too much weight. There's kind of an amount that's safe, an amount that's worrisome, so the hospital keeps track of that for us every day, and we check on that. And it is, hopefully, it'll be a good bonding time, a time for you to rest, hold your baby, look at your baby, relax with your baby, and just have good bonding. And all the hospitals in town have lactation specialists, and pretty much their routine is that if you're going to breastfeed, they're going to come in and try to help you. So we would strongly encourage you to work with lactation if you're planning to breastfeed. That shouldn't be a problem when you're in the hospital. But if you have problems when you go home, maybe the milk's not coming in very well, or the baby's not latching well, or we've had a bigger weight loss than we would like, then we can definitely get you hooked back up with lactation after you go home. There's several different resources with that to help you get the breastfeeding figured out. So I always tell parents, you know, any breast milk you get is better than none. We're here to help you. We don't want to pressure you if you decided it's not for you, but if you are interested in breastfeeding, we're here to help you any way that we can. Whoops. So for formula, some moms do like that because they feel like it's not all their responsibility. Dad can help feed the baby. I think formulas have come a long way. They're trying to make them as close to breast milk as they can get. So now all the formulas have these fatty acids in them, DHA and ARA, which are two fatty acids that we find in breast milk that are important for brain and eye development. And now they've started to add these probiotics, which are good bacteria that we all have in our intestines that help regulate our digestion. And so those are also found in breast milk. So now they're trying to put probiotics in formula. There's lots of different kinds of formula. Parents always ask me, well, which kind should I use? And I usually tell them one of the major brands is fine. Usually Enfamil, Similac, or Good Start are all fine choices. The standard infant formulas are milk-based, cow's milk-based, and then they have all these different special formulas, soy formula, what they call hypoallergenic formula, which doesn't have milk or soy in it. They have some gentle formulas, which are still milk-based, but the proteins are more broken down. They have thickened formulas for spitty babies, so the formula stuff can get really confusing. So my one point to you about formula is that I would kind of start with one of the standard ones if you're going to go that route. If you feel like your baby's having trouble with spitting or gassiness or trouble pooping, I would talk with your baby's doctor before you just started trying all the different ones, because that can kind of drive you crazy. We usually like parents to give a particular formula about 2 weeks before they say it's not working or the baby's not doing well. So I've had some parents go to the store and just get all these different kinds, and they'll say, well, Tuesday I gave them this kind, and Wednesday I gave them this other kind, and Thursday I did this other kind, and this day they pooped once. And, you know, it's very hard to kind of get a feel for what is wrong with the baby or what's helped or what's made them worse. So if you do feel like you want to change, then talk to the doctor about that. And also that you can ask your pediatrician if they have a favorite one, but I don't really have a favorite one. I think kind of the major brands are fine. With breast milk, once you get home, you're going to feed about every 2 to 3 hours. Some babies will cluster feed a lot of times in the evening, where they'll seem like they want to nurse about every hour, and that's okay. Sometimes we hope for a good stretch at night if they cluster feed in the evening, that maybe they'd give you a 3 or 4 hours stretch before they wanted to eat again. I tell moms with new babies, when you go home, for those first couple weeks, I don't want you to go longer than 4 hours without feeding your baby, especially if you're breastfeeding. So if you feed the baby at noon and it's 4 o'clock and the baby's not waking up, then you want to get that baby naked. You want to change the diaper, wipe them with a baby wipe, try to get them to wake up so that they're ready to feed again. So that's kind of our routine with breastfeeding, is we don't want to go longer than 4 hours, but most of the time that's not a problem. Most of the time the babies are ready to eat every 2 to 3 hours. Formula, you're going to go about every 3 to 4 hours. Same rule applies. I still wouldn't go longer than 4 hours when they're little between feedings. Your goal initially in those first week of life or so is about 14 to 16 ounces a day. So that's going to be, 1 to 2 ounces every 3 hours roughly. Newborn tummies are not very big. They're about the size of a newborn's fist, and they will stretch and grow those first few days. But if you give a brand new baby who's only 1 day old 2 ounces of formula, they're going to spit it back up at you. So you're going to go slow. If you're formula feeding at the hospital, the nurses will tell you, oh, just give them a half an ounce or 3/4 of an ounce to start. So if we get too much in that tummy, it's just going to come back up. And bottles, you're going to look for just BPA-free bottles, which I think most of them are now. That's that plastic additive that we don't like. Some people use glass bottles. That's fine. You're going to use a slow flow nipple to start, because the faster flow nipples for older babies, that's going to be too much of a rush or kind of drown your baby with milk if you do those fast flow nipples right away. And I think most of the bottles kind of come standard with a slow flow to start. Some things that we're going to do in the hospital while you're staying there, we're going to check, as I said, the temperature. We're going to make sure the baby can hold their temperature at a normal level. We're going to watch and make sure they've peed and pooped. We do a blood sugar after the baby's born to make sure that's okay. Sometime in that first couple days of life, we're going to check their hearing, and that's a law in the state of Nebraska. All babies have to have a hearing test. If you pass it, great. The hospital will give that information to your pediatrician, so we always note that in our new babies charts that they pass their hearing screen. That way, if you come in when the child's 2 and say, they're not talking very well, I don't know if they can hear, we can look back and say, okay, they passed their newborn hearing screen, so that's reassuring. If you fail the newborn hearing screen, we'll send you off to get a repeat test when the baby's about 4 to 6 weeks old, and there's a few places you can do that. Children's, Boys Town are usually the main places that we send you for hearing test follow-up. So a few times a year I have a baby that fails. Most of those babies end up being fine when they repeat it later, but we do like to confirm it and make sure every once in a while I'll have one that truly does have some hearing loss. So we want to know that, the earlier the better, then we can intervene when the child's young. If you have a boy and you want him circumcised, that should happen when you're in the hospital. Sometimes pediatricians do that, sometimes the OBs do it. You should ask your doctor who's going to do it so that you get that figured out ahead of time. And then as I said, we'll weigh the babies every day while they're there. We get concerned if the babies lose more than 10% of their birth weight. So that's kind of the calculation that we're doing when we see that your baby's lost weight from when they were born. Those big 8 and 9 pound babies can lose like a pound or more before we get worried, but the little 5 and 6 pounders can't lose as much. So it's all based on percentage of weight loss. And so the doctor will talk to you if we're on that borderline where we're close to 10%. They'll talk to you about either getting you back with lactation to see how much the baby's really getting from you, pumping, supplementing pumped breast milk if you have some, supplementing a little bit of formula if we're just not getting anything from the breast. So there's a bunch of different ways that we approach that. It's kind of individualized based on what's going on with your baby. And then one of the things that we do now with all our newborns is we really monitor them for jaundice. Jaundice is that yellow-orange color to the skin. It's really common in newborns, and there's a bunch of different reasons. Jaundice is from a compound called bilirubin, which is in our red blood cells. Newborns have lots of red blood cells because their body had to steal oxygen from mom, so they had to have more red blood cells to kind of steal mom's oxygen when they were inside the uterus. And now when they're born in the world, they don't need that many red blood cells, and those red blood cells start to break down and die, and that releases bilirubin, and bilirubin turns you yellow. Your liver is supposed to handle your bilirubin and get rid of it, but babies' livers are immature and they're not very good at it, so a grown-up could probably handle this load, but a little baby just sometimes can't keep up with how much bilirubin there is, and they can get very yellow. A lot of the jaundice is not a big deal, and their liver eventually catches up and it's fine. We get worried if that bilirubin level gets close to 20, but we also worry about how old you are when that happens. Usually babies kind of have their peak level of jaundice around day 4 of life, and so if you're only 1 day old and your bilirubin's already 15, then that's really worrisome because by day 4 you'll be way over 20, and we don't like to get it over 20. There's lots of things we do to help with jaundice. Sometimes just getting more volume in them, peeing and pooping helps your body clear the bilirubin, so that helps. Sometimes if they're not too bad, we can have you put them in the sunny window if it's summertime like it is now, and the sunlight helps get rid of the bilirubin by converting it to another compound that's easier for your body to get rid of. And if they're really getting too high, then we actually do something called phototherapy, which looks like a little baby tanning bed. And most of the time we can bring that to your house with a home health company, and we have the baby lay in this little tanning bed in a diaper and have that light shine on their skin, and that helps get rid of the bilirubin. So sometimes when babies are jaundiced early, we have to start that in the hospital, that phototherapy, and we follow bilirubin levels one of 2 ways. We either use a little sensor that senses it by just touching the skin. That's kind of our screening method. If the levels come back high, we usually like to confirm it with a blood test. We poke their heel because that's the most accurate. So most babies in Omaha get at least 1 screening bilirubin level the day that they leave, and that kind of helps us gauge where you're at. If you go home on day 2 and your bilirubin's 15 or 16, we're going to want to recheck you tomorrow. If you go home on day 4 and your bilirubin's 8, it's not going to be a big deal. So that's something that your doctor will be on top of, and the hospital will help check with that as well. Oh, and one thing I forgot to put on here on that last slide is, we just started a new screening about 2 months ago where the hospitals in Omaha are screening for what we call congenital heart disease. So those are malformations of the heart. And the way they screen for that is just checking the baby's oxygen level with a little probe. They'll put it on their hand and on their foot. And we like that to be above 90, but also that the reading in the hand and foot is very similar. If it has more than about a 5% difference reading, then we'll repeat it. And if it continues to be abnormal, then sometimes we'll do an echocardiogram, which is an ultrasound of the heart to make sure the heart structure is normal. So that's a new thing that we found. That's kind of a recommendation again from the American Academy of Pediatrics. It's a really easy test, painless, simple to do, and can pick up some heart disease that we might not otherwise pick up until the baby's really having trouble. So it's kind of a way to screen and be proactive for that. So that's one thing that'll happen to your baby as well. You might not even know it because they'll do it real quick in the nursery sometime when they're in there giving the baby a bath or something. But in case your doctor would mention that they failed it, then you'll at least know what they're talking about, and you can kind of ask about what the next step will be. Circumcision is up to you. I'm completely neutral on circumcision as far as what my parents want to do with their children. There's maybe a tiny bit of decreased risk of urinary tract or bladder infections if they're circumcised. And there's a decreased risk of penile cancer, but penile cancer is so rare that it's really kind of a negligible decrease because we just don't see very much of that anyway. Some people are doing it for religious reasons, so I really don't care. If parents want it done, it's fine. If they don't want to do it, it's fine. We just want to make sure you know how to care for it either way. If you do have a circumcision, they're going to do that sometime while you're in the hospital with the baby. And as I said, your OB or pediatrician will do that depending on what their preference is. We usually have you put Vaseline on the penis then after the circumcision. You do that with every diaper change until it heals. The skin is going to look swollen and scabby and yellow and kind of scary for those first couple days, and you'll think, oh my gosh, what were we thinking? We shouldn't have done it, but it's normal. We just keep the Vaseline kind of really slathered on there so that the diaper doesn't rub and irritate that skin that's kind of raw and trying to heal. When you wash it, you're not going to scrub on it. If you need to clean it because it has some poop on it, you're just going to take a wet washcloth and kind of drip it over there and kind of rinse it off. If you have persistent bleeding of the circumcision, that's something you'd call your doctor about. That's pretty rare, maybe once a year. I have a patient that has that. And so they'll kind of show you, they'll send you home with Vaseline, they'll show you how to do that in the hospital before you leave. But usually by 1 to 2 weeks of life, it looks normal. So it just takes a few days to heal. So I kind of talked about jaundice already. We talked about the increased bilirubin, the immature liver, and it peaks on day 4. We get concerned if it's close to 20. And so then we'll go home on day 2 to 4, depending on what kind of delivery you had. I like to see my newborns 1 to 2 days after they go home. And I'll tell parents on the day that they leave, I want to see you tomorrow. I want to see you Friday in clinic. This is why I want to see you. We're looking at the weight. We're looking at the jaundice. Sometimes we have home health go and see you. If we have a jaundice issue in the hospital, we can set up home health to see you right away when you go home. So it just kind of depends. Every baby's different. Our plan is different depending on what's going on with your baby. But most babies, we like to see you a couple days after you leave. When you get home, I think you're kind of wired. You're kind of that overtired, hyped up feeling because you've been up for 2 or 3 days straight and not really had more than an hour or 2 of sleep consecutively. So you need to just try to relax, sit down, rest, hold your baby. When the baby's sleeping, you need to try to sleep and rest, especially mom, especially if you're breastfeeding. So, you know, don't worry about what time of the day it is. A lot of moms say, well, I don't want to take a nap. I can't nap during the day. But it does help also with your milk supply if you're breastfeeding. An overtired, stressed mom is not going to make as much breast milk. So when you go home, you need to put your feet up. You need to drink lots of water. And you need to rest. Don't worry about the dishes or the laundry. That's why dad is there with you. Or maybe grandma will come help with that. And I think when you have your first baby, which I'm guessing a lot of you haven't had a baby yet, the reaction from your family who loves you is that everyone wants to come and see the baby immediately. And so you feel kind of rude saying, no, don't come over, but that baby is still going to look like a newborn in a week. So if you're exhausted, if you had a hard labor, if you had a tough recovery, it's okay to say, no, we're just really tired today. Why don't you call us in a couple days and we'll see how it's going. Because people are going to want to drop in, and it's hard. Then you feel like you need to entertain them and pass the baby around. And if mom's breastfeeding, then she feels awkward about leaving to go feed the baby when the people are there to see the baby. So just don't feel rude about that. If you're not up for it, you're not up for it. And the baby's still going to be a baby in a week. So don't worry about that. And then we kind of talked about when you go in that first office visit, that's one of my favorite visits because I get to see how things are going since you got home. I'm usually seeing people on day 3 or 4 after the baby's born. You're at your most tired. Mom usually cries, so it's fine if you cry during that office visit. Sometimes I almost cry because they're just so stressed and tired, and I feel so bad for them. But we're going to weigh the baby. We're going to see where the weight loss is at. If they look yellow, we're going to check the jaundice with a heel poke. We don't have that monitor in our office. I don't think very many clinics do because they're pretty expensive, and the blood test is more accurate. So if your baby looks jaundiced to us or we need to follow it up, we're going to do the heel poke. And we're going to see how feeding's going, and that's the time where I say, okay, well, you've lost 9% of your birth weight. What are we going to do? How's feeding going? Do you think your breast milk's in? Do we need to get you back with lactation? So those are all those visits. So when you come to that visit, that's kind of what we're going to focus on. We'll check the umbilical cord. We'll check the circumcision. We'll kind of look the baby over from head to toe again. But that's a hard one because you're really tired then. So we're just there for moral support. We're going to be your cheerleaders, and we're going to help you get through it. And if you have any questions, write them down because you're sleep deprived. So sometimes you think of a question the day before, and then parents will get there and say, oh, I had this question, I can't remember. So a lot of parents find it helpful to keep a little notebook they kind of mark down when they fed the baby, how many wets and how many poops they had, because we like to know that. And then they'll kind of jot down any questions. And that way you can bring that along, and I can look at it and see, okay, you fed about every 2 or 3 hours, and you had 3 wets, and you had 3 poops, and it helps me too. Usually when your baby goes home, you're going to see that poop start to turn colors. That's another question I ask. When you're in the hospital, the poop is that meconium, very black, sticky, tarry stuff. Once the baby gets all that out and starts getting breast milk or formula, and that starts going through them, then the poop is going to change. Breast milk poop is usually kind of a mustardy yellow color. It looks like it has little seeds in it. So usually by day 3 or 4 or 5, you should be having some yellow, seedy looking poops if you're breastfeeding. Formula feeding, it kind of depends. Some babies are kind of a green or brown poop, and they'll go once or twice a day. And some formula-fed babies still have yellow mustardy poops that are frequent. So that's a thing that we'll ask about. So then if your baby looks good and everything's great, we'll say, okay, go home and we'll see you when the baby's 2 weeks old. But if you're having trouble, sometimes we have to see a couple more times in there to see what's going on with the jaundice or the feeding. And then we always want to see all our babies back at 2 weeks. And HCM stands for healthcare maintenance, so that's another checkup basically is what that means. We're going to look at them from head to toe again. We're going to check their cord. Your umbilical cord should be off by 2 weeks of age. If it's not, we have medicine we'll put on there to help it fall off. We're going to make sure they're back to their birth weight. We give them 2 weeks to get back to birth weight after they've had that weight loss. And we're going to make sure that their newborn screen is back. That's one thing I forgot to mention they'll do in the hospital is they'll take some blood for the Nebraska newborn screen. That's another state law. And that checks for about 30 different metabolic and genetic diseases that can affect your baby early on in life, so we want to know right away. It checks for cystic fibrosis, sickle cell anemia, thyroid problems, and some other problems that are related to the way your body breaks down fat or sugar or protein, and that can, if those are abnormal, that can affect what you're supposed to feed your baby. So we need to know about those right away. So we'll make sure we have the newborn screen back by the 2-week visit, and just kind of go. You usually have more questions then. Things are calmed down a little bit. You're kind of trying to get a little bit of a routine. So a lot of parents feel like they're kind of back to feeling like a human being again. And they have things they want to ask, kind of how the baby's been doing, what the routine is, how they're sleeping, things like that. So we go over all that stuff at the 2-week visit. And then if everything's good, I see you back at 2 months. So 6 weeks later, which feels like a really long time when you have a newborn. I always tell moms, if you're worried in that 6 weeks when I'm not supposed to see you, you definitely need to call anytime. If you have questions, if you're feeding the baby and you don't think they're getting enough with breastfeeding, we can bring them in, we can weigh them, we can see how things are going. So I always feel like when I send them off at 2 weeks that I'm sending them off to college because they're not going to be back for 6 weeks, and that's such a long time with a newborn. So I want to make sure they know that they can come back sooner if they need to. And pooping and peeing, we kind of talked about that meconium at first for the first couple days. Our rule about wet diapers is actually the first day of life you have 1, the second day of life you have 2, the third day of life you have 3 wet diapers, and then you start to have more. As the milk comes in, you should have lots of wet diapers, 6, 7, 8 wet diapers a day once your breast milk's in. If you're formula fed, you're going to have more wet diapers sooner because the baby's getting more volume earlier. And breastfed babies kind of drive parents, well, I think all babies drive parents crazy with their pooping. Remember, it's not an emergency if they don't poop for a day, that's fine. That doesn't mean they're constipated. So we care about what the poop looks like. If it's soft, nice soft poop, then it's okay if they only poop once a week. And some breastfed babies will eventually end up like that when they're a month or two old. They'll go from pooping 10 times a day to once every week. And that really stresses their parents out. But if your baby's not seeming like they have a bad tummy ache, if they're not spitting up, if they're not terribly gassy, and when their poop comes out it's nice and soft, then that's okay. But you can always call us with those questions. Parents always ask about bathing. Usually in the beginning, you're just going to do it 2 or 3 times a week. When they're newborns, they don't like to be cold and wet, so you're going to make it a pretty fast sponge bath until that cord falls off. You just want to avoid the umbilical cord area. You're going to keep it clean and dry. We used to have people put alcohol on it. We don't really do that now. We've shown that it hasn't really made a difference in how quickly the cord falls off. Sometimes if the cord gets really gooey, kind of oozes or is bleeding, then I'll have parents do a little alcohol with a Q-tip on the cord to help dry it up a little bit. But usually just keeping it dry and leaving it alone, it'll fall off by the 2-week visit. And so that's one thing I'll check then. If it does, very rarely the umbilical area can get infected. The skin around the belly button will get really bright red and almost feel hot, or it'll get a really stinky discharge. Then you need to give us a call so we can look at it. It's pretty rare, but once in a blue moon we'll see that. And then parents always want to know what to do with the fingernails. Babies have really kind of paper thin fingernails that kind of get bent, or they'll get sharp edges and the baby will scratch their face. So you can take a little emery board and just kind of file them if you're afraid to clip them with the clippers. Sometimes they just kind of peel off almost. They're kind of hanging by half of a fingernail and you can just kind of gently peel it off. So people are afraid with the clippers that they'll make them bleed, but if you just do it real gently, usually you're fine. And then when to call us. And this is another thing your doctor should go over. I feel like I say this all the time. Every day in my life I'm giving this little speech to parents. But with newborns, these are when symptoms we want you to call us for. Fever's a really important one. Fever in a baby is very concerning because babies' immune systems are not as strong as ours. They're not as good at fighting infection. If they get an infection, they can get really ill really quickly. So a fever in a baby is kind of an emergency. I don't want you to check their temperature all the time because that'll drive you crazy. When they're in the hospital, the nurses are going to do vital signs and check their temperature about every 4 to 8 hours. When you go home, you're just going to treat the baby like a regular person, and you're not going to check the temperature all the time. I always say, don't check it unless you think something's wrong. If the baby feels hot, you're going to unwrap them. Then you're going to do the rectal temperature. If the baby's really fussy and irritable, you can't get them settled down, we want you to do a temperature. If the baby won't wake up to eat, we want you to check their temperature. And I really only want you to do it rectally when they're little. When they're older, you can check it other ways. But in a newborn, we want that core temperature, and that's 100.4 rectally. And that's what we consider a fever. A lot of people think 99 is a fever. It's not. So grandma's going to say, well, 99 is a fever, but it's not. So for our world, 100.4 is a fever. That's 38 degrees Celsius. That's where we come up with that weird number. And if your newborn has a fever, you need to be seen right away. If it's during the day, call the doctor's office and say, my 1-week-old has a temperature of 101 rectally, and they're going to have you come right over. And if it's at night, you need to just go to the emergency room. If you call the nurse line, that's what they're going to tell you. I think it's a waste of your time. I always tell my parents, if it's possible, come to Children's, and that's not a plug for Children's. It's just that other ERs sometimes don't see a lot of newborns, and they get really nervous when they see a sick newborn. And sometimes the treatment that they need can get delayed just because they don't have all the stuff that they need. So if you are in decent driving distance, you'll just get a quicker, easier kind of result if you go there. And in addition, we have to keep babies who have fever in the hospital for a couple days while we run some tests. So if you go to a hospital that doesn't admit little people, you're going to end up here anyway. So it'll save you an extra trip. If the baby's not breathing, they're turning blue, then you're just going to go to the closest place that you have. But if it's just a fever and they're still alert, color's good, then we'll have you come here. The jaundice going up, we want you to call. Most of the time you're going to kind of have a plan for that because you're going to know what it was when you left the hospital and you're going to be coming into your pediatrician. But I always say, wow, if you wake up in the morning and your baby looks like a pumpkin, you need to call me right away. Baby's not waking up to eat. Sometimes jaundice makes babies really sleepy, but illness can also make them sleepy. So if your baby was normally eating every 2 to 3 hours and now all of a sudden it's been 7 hours and you cannot wake them up, then you need to call us because that can be a sign of illness. Vomiting that's projectile, that one is a little bit kind of a more difficult one to quantify because a lot of parents call any vomiting projectile, I have learned over the years. So we think about things that would obstruct the bowel, that would cause really forceful vomiting where it's shooting across the room and hitting dad. Babies that just kind of dribble or spit out is not really projectile vomiting. We worry also about green throw up that looks like bile because that's another indication of an intestinal obstruction. So if you ever have green throw up, you need to call us right away. But if you have a lot of vomiting, it's still a good idea to call. Sometimes when moms are breastfeeding, their nipples will be really sore and cracked and they'll bleed a little bit. And the baby can swallow some of that blood from mom's breast and then the baby will spit up and it'll have blood in it. And then that's very alarming to their parents and they'll think, oh my gosh, why are they spitting up blood? And they'll rush them in. And that's actually probably not that big of a deal because usually that blood-streaked spit up from the baby is usually swallowed maternal blood that just came back up. So definitely give us a call, but usually it's not necessarily a need for an ER visit or panic because we do see that a lot. And especially if mom says, oh yeah, I'm really sore, my nipples have been cracked and bleeding a little bit, then that's usually what it is. That soft spot on the top of their head, if it's bulging up, you can see it without touching it, you can see the stuff bulging up, then that's a sign sometimes of meningitis, so we need to see them right away. A baby that's just inconsolably fussy, you cannot calm them down. You've fed them, you've changed them, you've rocked them, you've made sure they weren't too hot or too cold, then you need to call us because that can also be another sign of illness if you have an inconsolable baby. And then just make sure that everybody is healthy and washing their hands. When you have visitors, if people are sick, they should wait until they're better to come and visit your baby. You don't want to take them out to a big family reunion when they're a week old and 40 different people are going to hold them and kiss them and touch them because that's a lot of germs for a newborn's immune system. So you're going to lay low, you're going to let visitors come over and see them, they're going to clean their hands, and you're going to try to avoid those big crowds of people. Now, if you have the baby in the car seat and you need to go to Target because you haven't been out of the house in 2 weeks and you're going crazy, I think that's fine because you kind of have the baby in a confined space. You're not going to let people touch them and breathe on them. You're going to clean your hands before you handle the baby again. That's fine. But just try to avoid getting them passed around to lots and lots of different people. And I think that with babies, you know, the crying is always difficult. Why are they crying? Are they crying because they're hot? Are they crying because they're hungry? Are they crying because they're cold? Are they crying because they just want to be held? So there's lots of different reasons, and you'll kind of learn those cries. You'll learn their schedule a little bit. Some babies seem like they're just, you know, terribly mad if they have a wet diaper for even 5 minutes. They're screaming about it. Other babies don't care as much. So you're going to learn those different cries, the pain cry or just a little kind of fussy cry or the I'm hungry cry. And so one thing we'll tell parents is if you've tried all the normal stuff, you changed their diaper, you fed them, you can use these 5 S's. That's from a book called The Happiest Baby on the Block. And that's kind of trying to recreate the womb again for the baby. That's what they want. So we swaddle them up tight. You kind of hold them on their side. You sway with them, kind of that swaying motion that mom would have had when they put swing here, but it's more of a swaying motion and kind of that shh, shh, shh sound, that shh, shh, shh. And they can have something to suck on, a pacifier or your clean finger or their own hand. Or sometimes they just want to be at the breast and kind of use that as a pacifier. That usually works. But so that's what you're going to try to do. Babies don't like to be out in the open, cold, in the crib or just laying out in the middle of the room. They like to be swaddled up tight and held. All the parents always say, well, they sleep fine if I'm holding them. That's because they wish they were back inside mom, and when they're snuggled up next to another warm body and they can hear your heartbeat and feel your warmth and they're tucked in tight, that's their favorite position. So don't try to fight that. It's going to be gone before you know it. So just hold your baby lots. You can't spoil them in those first 3 or 4 months of life. So if they want to be held, then you just should sit and hold them, right? And then dad can have an excuse to watch football while he's holding the baby. And we kind of talked about spit up, but again, certain things make us worry about spit up. All babies spit up at some point, so spit up isn't really scary to us. You can avoid lots of spit up by burping well, trying not to overfeed. Like I talked about, if you give your 1-day-old 2 ounces of formula, they're going to spit up. So you kind of try to make sure those amounts are appropriate for how old they are, and your doctor will talk to you about that. Burping, you kind of have to be careful with that. Breastfed babies usually aren't swallowing a ton of air, so don't feel like you have to stop every 5 minutes and burp them. I usually tell parents you're going to burp once in the middle and once at the end of the feeding. So if you're doing a bottle, once in the middle of the feeding, once at the end. If you're breastfeeding, you might burp them once when they get off one side and then once when they get off the other side. And my favorite position for burping is to sit them on my lap, kind of hunched over, kind of holding their chin and stuff with my one hand, and then I'm kind of patting their back with my other hand. Some people like the over the shoulder. I never had as much luck with that. If you try to burp them for 5 or 10 minutes and you don't get one, then I would just stop trying. Sometimes if you lay them on their back and kind of do a little bicycle with their legs or flip them over on their tummy and rub their back, you'll kind of work those air bubbles through. Remember, we all have air in our intestines and we're moving around all the time, and that helps get it out. But babies are just laying there, so you kind of have to change their position to help work those air bubbles out sometimes. So sometimes if you tried for 5 or 10 minutes and nothing's happening, lay them down, work their legs, then sit them back up, and sometimes you'll get a good burp. But sometimes you're just not going to get one, and it's fine. Worrisome symptoms like I talked about, projectile vomiting, green vomit, blood maybe, but usually if you're nursing, it's not a big deal. We worry about poor weight gain. So if we're throwing up and throwing up and throwing up all the time and we're not gaining weight, then that's something where your doctor's going to intervene. If they're what we call a fat happy spitter, so they're spitting, some dribbles out after every feed, but they're gaining weight like crazy and they're not fussy, then there's nothing you can really do. It just has to get better with time. And if babies have problems breathing while they're eating, they're choking, gagging, sputtering, coughing, turning blue, then you need to let your doctor know about that too. So we worry about breathing problems with eating. Babies should be able to suck, swallow, breathe, so you'll have kind of a rhythm to it. They'll take several swallows and then they'll kind of stop and breathe for a second, and then they'll have that rhythm again. So once you have a good milk supply, that's what you should kind of see. These are kind of things for a little bit later, not usually in the first couple weeks, but some babies around 1 or 2 months of age will develop an intolerance to the protein in milk and soy. It seems like it's getting a little more common the last few years, where they'll get really fussy, they'll have trouble gaining weight, they'll get spitty. We'll see lots and lots and lots of poops, 20 or 30 a day instead of 10. And one of the big signs to us is if you see blood or mucus in their stool, that can be a sign of intolerance, kind of an allergy or what we call a colitis from irritation to their intestines from milk or soy protein. And it can make them really, really fussy. So if you see blood or mucus in the stool, you need to let your doctor know. If you're coming in and saying, well, gosh, they're just so fussy, they're never happy, they're never satisfied, they always seem like they have a tummy ache, that might be one of the things on the list that your doctor thinks about. If we do think they have it, what we usually do is try to remove those proteins. So if you're breastfeeding, mom has to go on a diet that's free of milk and soy, which is a tough diet, but I do have moms that are able to do it. Or we use a hypoallergenic formula that doesn't have milk or soy in it, and that usually allows their intestine to settle down and heal. The good news is they don't usually have this forever. Most kids outgrow it by 9 to 12 months of age, and then you can go back to regular milk and soy and be fine. So it's just something you kind of have to live through, but sometimes those babies are a challenge. Sometimes they're very fussy, very hard to live with. Sometimes they don't gain weight well, so we definitely are there to help you if we think that's the issue. And then sleeping. We talk about sleeping is a big deal, obviously for parents. We talk about back to sleep and SIDS, and we'll do that on the next slides. Babies have their days and nights mixed up when they're born. Most babies are used to being awake and active at night when mom was resting, when mom was moving around during the day with her pregnancy, just doing her normal activities. That motion kind of lulled the baby to sleep. So when the baby's born, it wants to be up at night and sleep during the day. So it takes a while to get that reversed. You want to keep those nighttime feedings really brief and boring. Don't turn on all the lights. Don't have everybody get up. You want to just have a low light on when you're trying to feed at night, or just the light of the TV or something. You want to try to put that baby right back to bed when you're done. During the day, the babies are going to sleep no matter what you do. You can't keep a newborn awake all day. But don't be afraid to be loud or run the vacuum or have people talking around the baby even if they're sleeping, because babies kind of need to learn that the daytime is for awake and the nighttime is for sleep. So it takes a month or two to get that switched around. So that's why you have to try to sleep when the baby sleeps. And colic, you know, colic is something that's a fussy baby. We don't always know why. I think a lot of babies with colic end up getting tried on a different formula or medicine for reflux because they're fussy. But usually the definition of true colic is they're only fussy in the evenings for a very set period of time. You can usually say, well, they start getting fussy at 6 p.m. It's done by 9 or 10 p.m. Usually more than 3 hours a day for more than 3 weeks. But it's usually a very defined period of time, and most of the time evening, and the rest of the time they're actually pretty good, happy babies. We think it's kind of a developmental thing. No one's ever been able to find a magic solution for colic. They've even seen it in animals, so we think it's kind of part of our just regular evolution and development. Some babies are worse than others, but you can talk to your doctor about that. But it is something where one night they might like the swing, the next night you might have to go for a drive. Sometimes nothing works. You just kind of have to live through it. But you talk to your doctor about that if you're having trouble with colic, and they'll try to make sure it isn't a tummy problem or something else. With SIDS, we talk about sudden infant death syndrome, and there's a lot of education about that. The hospital will make you watch a video about safe sleep practices, but that's kind of one of our top causes of death in children under a year. The peak incidence of SIDS is between 2 and 4 months, so I'll always have new parents say, oh, you know, we got home from the hospital and I couldn't sleep because I had to make sure the baby was breathing, and really the most time I see SIDS is actually a little older, so we don't get quite as worried about it when they're just a few days old. The main thing is just trying to make a safe sleep environment, as safe as you can for your baby. So that nice firm mattress, no blankets or stuffed animals or crib bumpers or pillows in their bed. You want to have really the baby in a bed that's designed for a baby. You don't want a baby on a pillow top mattress in your bed with a comforter. That's not a good environment for them. You're going to lay them on their back, not on their tummy. Pacifiers, there has been some literature that's shown falling asleep with a pacifier seems to help prevent SIDS. You don't need to have it in the whole night, and we usually don't encourage pacifiers in the first couple weeks of life when you're breastfeeding, but later on when you have good breastfeeding established, then you can use one at bedtime if you want. Smoking, for many reasons, smoking isn't good, but SIDS is just another one on the list of why we try to avoid smoking. Is babies who are in the house of a smoker tend to have a higher risk of SIDS. We try to prevent overheating. I think our inclination is the baby's cold, we need to bundle up the baby. And we do like to swaddle them, but that doesn't mean you have to dress them in 5 heavy layers and a heavy blanket. You can use one of those really thin blankets to swaddle them and not overheat them, or those sleep sacks or something like that. So you just kind of want to have them in the same layers of clothing that you have, and you want to keep your house on the medium to cooler side. You don't want to set your thermostat at 75 or something. You want to make sure that it's relatively cool. Better air circulation seems to help, a fan in your room. So some people, I've had people buy these monitors to say if the baby's breathing, where they lay this pad in the crib and it's supposed to alarm if the baby doesn't breathe. And I really don't think that any medical people would recommend those. A lot of those really just give kind of false levels of comfort. Even when we send babies home, like preemies from the NICU on a true, what we call apnea monitor that monitors their breathing, most of those alarms are false. So there's been a lot of studies that show even us as physicians sending babies home on a real apnea monitor is probably not that useful. You do want to do some tummy time when they're awake to help strengthen their back and neck so that they can lift their head up if they need to, but you don't want to sleep with them. And then the newest thing that I tell parents is that we do have some evidence that babies who sleep near mom have a lower risk of SIDS. Not with mom, but near mom. So having that bassinet or pack and play by mom in your room, near your bed, there's kind of moms and babies are in sync with their sleep patterns, and we kind of, as moms, almost have a sixth sense, and so they have shown that they'll be monitoring a mom and baby sleep pattern and a mom and baby's breathing pattern. And when the baby has an alteration in their breathing pattern, the mom will actually arouse and stimulate the baby and not even realize she's doing it. So it's a good idea to have your baby close by in the beginning. You can transition them to their own room when they're 3 or 4 months old if things are going well. Some of the baby movements parents worry about, babies do have a lot of reflexes that are different than the rest of us. They have that startle reflex where they kind of jerk their arms and legs. They do their rooting and sucking. If you hold a newborn up and kind of stand them up like they're going to walk and you put pressure on their feet, they'll lift the other foot up like they're going to take a step. They have a grasp reflex. If you push your finger on their palm or the sole of their foot, they'll grasp around it like a monkey. Babies really cross their eyes a lot. That's normal. Sometimes their eyes will kind of roll back when they're going to sleep, and you'll think like, oh, are they having a seizure? Why are they doing that? But that's normal. Babies have really immature nervous systems, so they have a lot of these funny, jerky movements. Any worrisome or seizure-like movements to us would be like a rhythmic jerking that you can't stop. If a baby just jerks a couple times, you should be able to put your arm on it and stop it. But a seizure is going to be a movement that you can't stop even if you put pressure on that side. A really floppy baby that's limp like a rag doll is worrisome, or a really stiff baby where you can't bend them. Or if they're not moving one side, we do sometimes see that if they have a birth injury or something, they won't use an arm if they had a pinched a nerve or something like that from a birth problem. So those movements are more worrisome. Normal things, sneezing is very common, hiccups are very common. Those are both things we don't worry about. I think every new parent I've ever known that has their first child will either call or come in and say, my baby's really congested. I think they have allergies. I think they have a cold. But newborns really just sound congested. We put on there they breathe like Darth Vader. Babies like to breathe through their nose. Their nose isn't very big, so any little bit of mucus, or if they spit up and it kind of went up the back of their nose, kind of sits in there, and then they have that very kind of raspy breathing. The hospital will give you one of those nasal aspirators. It looks like a bulb, and you can use that. I always recommend you have some what we call nasal saline drops, which are just little saltwater drops. You can buy those anywhere. One brand is like Little Noses or just generic Target brand or whatever's fine. But if you feel like your baby sounds rattly, like they have mucus in there, it helps to put a little bit of saline drops in their nose and then try to suck them out. It'll help loosen up the mucus. But babies sound snortily and raspy and congested, and those are very normal things, and they'll get better as they get older. A lot of babies can get a clogged tear duct. That's really common. We all have a little tube that connects our corner of our eye down to our nose. It's small when you're a newborn, and if it gets kind of plugged up, then your eye will start to water and matter. And so we have parents do what we call tear duct massage, where they just push down with their finger on the corner of the baby's eye, and that helps open that tear duct back up so the tears can go through. So mattery eyes are pretty normal, but definitely we can certainly talk to you about that if you're having that problem, or your doctor can look at that. Sometimes they get white patches in their mouth. That can be from a yeast infection called thrush, but sometimes they can also just kind of get a milk coating on their tongue. So if you see white patches, we usually tell you if you can't wipe them off with a washcloth, then they're probably thrush, and you should let your doctor know. If they seem to wipe off, then that's probably just milk residue. And then fingernails we kind of already talked about. Babies get lots of rashes. Most of those are also no big deal and nothing to get too worried about. We usually don't treat them. Erythema toxicum kind of looks like a lot of bad bug bites. They usually get that when they're in the hospital, day 1 or 2 of life, and it'll be kind of scattered over their body. Sometimes they'll even have a little yellowy color to them. Nobody knows why they get it. It goes away on its own. You don't have to do anything about it. Baby acne is more on the face, kind of little pimply rash. I feel like I see more baby acne in breastfed babies because I think they're still getting some of those hormones from mom that kind of wreak havoc on your skin sometimes. Usually we just tell parents to gently clean those areas with water, or you can use a gentle soap like Aveeno. And if they seem really irritated or dry, you can put some Aquaphor ointment on it, which is just a petroleum jelly ointment. Milia is just little tiny white bumps on their nose. I don't think we really have a good picture of that, but that's another normal rash, probably hormonal, doesn't need to be treated, won't cause any problems down the road. Cradle cap is kind of almost like dandruff on a baby, kind of those greasy yellow flakes. Usually we can get some relief from that by just good cleansing and kind of scrubbing them with a brush, sometimes baby oil or even olive oil people do on the scalp, or if it's really bad, I'll have you wash the baby's scalp with Selsun Blue, which is an anti-dandruff shampoo, just a couple times a week usually helps. And then there's all kinds of different diaper rashes, which is really kind of beyond what we have time for. But yeast isn't, if they have thrush in their mouth, a lot of times they have a yeast diaper rash, and there is medicine they need for yeast if they have it. That bottom picture is a baby that's getting phototherapy. They have their little mask on, and you can see there's a light shining on them. And I always tell parents, you know, you're going to get advice from everybody, the grandmas, the aunts, your friends. Just take some of that with a grain of salt. People like to Google and look stuff up on the internet and diagnose your child with whatever. And so, and the way things grandma did it may have been fine and worked for her children, but we may have a little bit safer, easier way to do it now. So if grandma says, well, you need to give the baby you know, a raw egg in their bottle, which they used to do. Please don't do that. Please call your doctor first. Or you guys didn't sit in a car seat, you know, so we don't need to have the baby in a car seat. Yes, we do. And what works for one baby doesn't always work for another, and that's true in the same family. So when moms have had more than one child, they'll say, well, I did this for my first one, it worked just fine, but every baby's different. So remember that, and just no silly questions. I would rather have 10 people call me with an easy question than have one person not call me and have it be a real, true emergency that the baby's in danger and we weren't able to intervene as soon as we could have because the parents felt fearful of calling. So we never want you to feel afraid of calling. I think a lot of parents think, oh, I'm just being paranoid. But if you're worried, then you should call. And that way we can talk you through it. And just remember to save a little grown-up time for yourselves. Mom, you need to get out of the house once in a while, so go for a walk around the block. If it's not 105 degrees, put the baby in the stroller, put the shade over him, walk around the block. It'll be good for your mental health. And then if you have other siblings, just try to carve out a little time with them one-on-one so that they still feel special and loved by mom and dad. The toddlers kind of regress, but after a month or two, everybody kind of settles in and gets into kind of normal life again. We talk a little bit about shaken baby. I think that's another video you have to watch at the hospital. But if the baby's really been fussy that day, you're having a terrible day, and you just feel like you're at your wit's end, you know, nobody ever died from crying. Lay the baby in their crib. Go outside for 5 minutes. The baby's going to be fine when you get back. You need to calm down if you do get to that point, or call somebody for help. And just, you know, I think a lot of parents are worried, if I don't do this right, or how the book says, or what my friend said, I'm going to mess them up. And you know, you're not going to mess them up. So you just need to love them, and you need to hold them and cherish that time because it's going to fly. So that's the end of my talk. Do you guys have any questions for me? That was a long talk. That was a lot of info. Now you'll all be experts when you go to the hospital and they tell you all the things they're going to do, and you'll be experts on jaundice and feeding and peeing and pooping. Yes, you have a question?
Breastfeeding, like how long should each session last?
That's a good question, and that's really variable. I think a session of breastfeeding can last from 10 minutes to an hour. It kind of depends on where you're at in that stage. In the beginning, when you just have colostrum, sometimes the baby's on there for a long time because they're not getting a lot and they're kind of working on it. When you have a good milk supply and you kind of get more in a routine when they're a month or so old, most of the time 15 minutes. But those first couple weeks, you might have that baby on your breast for 45 minutes one time and 20 minutes another time, and it's pretty variable. And bottle-fed babies, I will say this, most bottle-fed babies should be able to drink the amount that you're feeding them in about 15 minutes too. It shouldn't take a bottle-fed baby 45 minutes or an hour to finish a bottle. So I have had babies where they weren't latching on well to the particular bottle that the parents used, and they just, you know, for whatever reason, their jaw muscles, they weren't able to get a good seal and get that milk out, or maybe the nipple wasn't right. So if you're bottle feeding your baby and it's taking an hour to drink an ounce or two, then that is not normal, and you should ask your doctor about it, or they might recommend you that you try a different kind of nipple or bottle. So there's lots of different bottles out there, and what works for one baby might not work for another baby. So that's a little pointer for that. Well, sorry I went over. Oh, do you have another question? No, it's okay.
What would you consider a good steady weight gain? Because I know they lose at the beginning.
Yeah, that's a good question. So those first 3 or 4 days they're going to lose, but then when we start to gain, we like about an ounce a day. Half an ounce to an ounce a day. We really prefer an ounce. If you gain 5 ounces in 7 days, we're pretty happy. If you gain 3 ounces in 7 days, that's about a half an ounce. We'd really like to see more than that, so we follow that trend. But our general rule is about an ounce a day, or about 6 ounces in a week. So, yeah.
How long should you only do the rectal temperature?
Well, that depends. If you're like me, then you're going to still do it on your 5-year-old because I'm mean, and they're going to go to therapy someday. At least in the first year of life, we'd really prefer it. That's a whole other talk about fever, but if you really want to know what their temperature is, you should do it rectally until they're at least one. We just see so much variation with the ear and the forehead and the under the arm. I just don't even believe them, because I've seen kids with an underarm temp of 98 who feel hot, and then their rectal temp's 103. So my children still got rectal temps when they were 4 or 5. But the thing is, which is a different talk for a different day, but a lot of parents feel like, well, if they have a fever, I need to check it every half an hour, and we don't advocate that. Once you establish they have a fever, then we don't need to know every single temperature reading every half an hour. We just need to know that they had one and where was it, and then what are their other symptoms. So I don't think anyone would be happy if you took their rectal temperature every 30 minutes. But yeah, if somebody gets you one of those ear thermometers, and you can exchange it and get some other thing you really need, I would do that, because those are like $70, and a rectal thermometer is like $5, and that's all you really need. So just don't use a rectal thermometer for the oral later, right? Okay, all right. Any other questions, you guys? Okay. Well, everybody, good luck with your pregnancies. I meant to bring cards and I forgot. My office is at 96 and Giles in La Vista, and I have 2 partners. We're always taking new patients. We'd be happy to see you with your baby, or have a meet and greet at our office. Those are no charge, so if you're interested, let us know. And we have like 9 other offices in town, so we'd love to, all of our docs would love to take care of your baby and watch them grow up. That's what we love to do. So have a good night and stay cool. Thanks.